Everyone, thank you so much for joining us for this menopause talk. We are thrilled that so many of you are interested in this topic. I wanted to introduce myself, give you some general housekeeping items, and then turn it over to our incredible guest, Dr. Cheryl Kingsberg. So just to introduce myself first, my name is Jessica Levin. I am the Menopause Talk Director for Let's Talk Menopause. Let's Talk Menopause is a national nonprofit changing the conversation about menopause so women get the information they need and the healthcare they deserve. This is designed for information purposes only. We are not here to get you professional advice, diagnosis, or treatment. Please ask your medical professional for that. The other thing is we are turning off the chat. So please ask your questions in the Q&As. We know there are going to be many questions on this topic, so we will try to get to as many as we can. And we are hoping, if we can't, and there's still many questions, to ask Dr. Kingsberg to come back to do a question and answer with us so that everybody gets their questions answered in the way they want them to be answered. So now I'm going to introduce our guest, and her name is Dr. Cheryl Kingsberg. And Dr. Kingsberg is the Behavioral Division Chief in the Department of OBGYN at Cleveland Medical Center, and she is a professor in the areas of reproductive biology, urology, and psychiatry at Case Western. And her areas of clinical specialization include female sexual disorders, menopause, pregnancy, and postpartum mood disorders. She is the past president of North American Menopause Society and of the International Society for the Study of Women's Sexual Health. And she now chairs the advocacy committee of both organizations. She's also a prolific researcher and writer, has authored over 100 peer-reviewed publications, and is the co-author of a textbook on treating female sexual disorders. So Dr. Kingsberg, thank you for being with us today. We greatly appreciate it, as I know our audience does. And I'm going to start with an overall question, because many OBGYNs don't even ask their patients about sex. And yet not only have you made this a priority area, but you have gone into a territory that few people dare to venture into: sex in middle-aged and older women. So can you explain to all of us why you have prioritized this area?
Well, sure. First of all, thank you for inviting me. Any chance I get to talk about sexuality in midlife, it's an opportunity, and to be able to talk to women about this just makes my day. So thank you for inviting me. You said, why make this a priority? Really, the funny thing is that menopausal sex sometimes feels like it's what we call an oxymoron, and that is just not the case. Most women, as they are aging, want to remain sexually active, and active means with themselves, with a partner. It doesn't really matter with whom. They want their sexuality. And so it is sort of an ageist society to assume that women of a certain age shouldn't be interested in sex or have sex. So it is so important that we get rid of that myth. First of all, get rid of that myth. And then back to the practitioners. It's not just OBGYNs, by the way. It should be every healthcare professional should be comfortable talking about sex. They're not. I try to get them in medical school to be able to sort of get them used to the fact that, yes, their mothers still remain sexually active, even though they kind of cringe. But primary care clinicians, OBGYNs, nurse practitioners, they all need to be aware that sexual health is important to physical health, right? And physical health is important for sexual health. And who's going to address it? It needs to be their professionals.
And when you think of women's sexuality, you have often said you adopt a biopsychosocial perspective. So can you clarify what that means for everyone?
Yes. It's a mouthful, and I think Donna can put up the slide of that. So when we think about sexuality, we really want to think about it from what I call a biopsychosocial perspective. That is, sexual health and sexual dysfunction really are comprised of these four related factors, and you can see they can overlap. But when I'm looking at assessing what might be going on with somebody's healthy sexuality or dysfunctional sexuality, I look at these four components. There are biologic factors that contribute to sexual health or sexual dysfunction. Your overall health, by the way, will absolutely impact whether or not you have a healthy sexual function. But we also look at hormones. Certainly estrogen is important for and for overall health. Testosterone is important for sexual drive. Neurotransmitters absolutely play a huge role in sexual function in terms of. So when we look at the biologic factors, certainly health functions, diabetes, cardiovascular disease will interfere with healthy sexual function. So that's the biological piece of biopsychosocial. Psychological factors include depression, anxiety, performance anxiety. Men tend to worry about gaining and keeping an erection. Women tend to worry about their performance. How do I look? Am I going to be able to reach orgasm? The more you start to worry, am I going to reach orgasm, the less you're going to be able to reach orgasm because now you're distracted. So psychological factors. Sociocultural factors absolutely play a role. So if your cultural background, religious beliefs are supportive of women being sexual, then that will be promoting healthy sexuality. However, if your religious or cultural background says sex is shameful, it's dirty, women aren't supposed to enjoy sex, that can get in the way of healthy sexual function. And finally, the interpersonal factors. That is the quality of the relationship a woman is in her sexual life. So if everything else is going well, biology is fine, her beliefs are fine, but she is in conflict with her partner, or if she plain old doesn't like her partner, that's not going to be great for her sexual life. On the other hand, I will see plenty of women who will come in and say, everything else in my relationship is good. You know, we're best friends, we have shared values, we enjoy each other's company, but I've lost my interest, or it hurts when I have sex. And that, you know, when we look at all of those pieces and parts, it allows the clinician or me to be able to look at what might be going on to say, oh, it's the biologic factors we need to address. Oh, or it's the relationship issues. So we look at it from this biologic or biopsychosocial that are interfering with healthy sexual function.
I mean, that's really helpful. Another thing you've done that is very helpful, that has been very helpful to me, is when you think about women's sexual challenges, you have divided them into four categories of desire, arousal, pain, and orgasm. And I wanted to take each of those in turn and have you explain what they mean, what may cause the problems during and after menopause, and what treatments may be available. And I want you to start with desire, and especially how you talk about two different types of desire, which was kind of revelatory to me.
Sure. Well, you know, in general, when we look at sexual concerns that women will have, there are really kind of four categories. There are problems with desire, which is the idea of wanting, right? That's one's appetite for desire, for sexual activity. Then there's arousal, which is the body's ability to feel pleasurable sensations during sexual activity. Orgasm, which is the release of all sexual tension experienced as pleasurable. And then, of course, pain is certainly a problem, but many women will experience pain with sexual activity at some point in their sexual lives. So going back to your focus on desire, it is the most prevalent sexual problem for women, by the way. So not only is it interesting to you, but it is the one we should talk about the most, because while postmenopausal women often will experience pain with sexual activity, desire is the most prevalent problem across all ages. About 1 in 10 women would meet the criteria for the desire disorder, which we call hypoactive sexual desire disorder, or HSDD. So when we think about desire, think about appetite, think about wanting. Now, desire doesn't mean you're going to act on it, right? I could have an appetite for ice cream I'm not going to act on that. And so women might have an appetite for sexual activity, but not necessarily act on it. So it's important to think about sexual desire as wanting. And so when women lose their desire for sexual activity or lose desire for sex, will say, I want to want, right? That is the key phrase. I want to want. I want that back, right? Because a lot of times I'll get the pushback. Well, if you don't have any interest, then what's the big deal? It's a big deal because women are distressed by it. And that's actually what meets the criteria for a diagnosis. If you don't have any interest in sex and you're not bothered by that, and you label yourself as asexual, then that's perfectly fine. It's the women who come into my office and say, I used to have desire, I want my desire back. And that's a big problem. Now, to your point about the two different kinds of desire, there is really a sort of a spontaneous drive, which is your appetite, right? You could be on a desert island and it would be your biologic drive, if you will. How often would your body signal to you with no other distractions? How often it might be interested in a sexual outlet, right? And so some of us might have the drive to be sexual once a day, some of us once a week, some of us once a month, some of us every leap year, right? There is a range of our drive, but that is spontaneous. Then there is what we call responsive desire. And I think Donna can put that up to see the difference in what would be called that spontaneous drive, which is, your own biologic interest. And here we have the sort of Rosemary Bassan's responsive desire model, or a circular model that says, while spontaneous drive might be there, many women may not really have that drive anymore. And I have in the title of the slide, Sex and Aging, because this is very true in long-term relationships, right? When you're in that new relationship, and if that new relationship occurs when you're 20, 40, 60, or 80, it's not the age of the person in the relationship, it's the age and the length of the relationship. When you're in that new phase, we call it limerence, it's passionate, you're aching for sex, you can't wait to see your lover, right? But after a while in a long-term relationship, that changes. And many women will wonder, have I lost desire for my partner because I don't like crave him or her as soon as I see them. It's really sort of not as spontaneous. And what we want to reassure women or men is that in those long-term relationships, oftentimes that spontaneous drive, that grand passion isn't there, but women will choose to engage, initiate, or be responsive to a partner's initiation, even though they're sexually neutral, because of other reasons. They know that it will create emotional intimacy, or they read in Cosmo magazine that burns 500 calories, or they know that it will make their partner happy. For those reasons, they may start to engage in sexual activity, even though they're kind of doing their grocery list a little bit in the back of their heads, they're a little distracted. But once they start to engage in sexual activity and there's enough stimulation, their body starts to get aroused. And with that arousal, they start to get a little turned on. And then the desire kicks in, right? That becomes what we call responsive desire. They're kind of neutral to start, but once they get started and they are not interrupted by either pain, because that will shut down the cycle, or they're interrupted by, a knock on the door from UPS or something, or Amazon these days. So as long as there's no interference and there's enough arousal, it's then that desire kicks in. And then it's the aha moment of, sex. Why was I so hesitant? We should do this more often, right? And that's responsive desire. That is not necessarily dysfunctional. And I just want to reassure people in those long-term relationships that if it kind of kicks in after the fact, unless they lose that desire and they have no desire, even responsive desire, which would be a problem for them, that may be a normal phase for them. So for me, it's kind of like how I see going to the gym, right? I have no biologic urge to work out, no spontaneous drive to go to the gym. If I waited for my own spontaneous urge to go, I would never work out a day in my life. So I don't rely on that. I just wait. I get to the gym, I get on the treadmill, I work up a little sweat, my heart rate's up. And once it's up, then the smile comes on my face and I say, oh, this feels great. right, then I'm happy I've come. So that would be responsive desire. So for women who have no desire, we absolutely want to treat that. For women who have more responsive desire, that would be a normal phase of a long-term relationship.
Dr. Kingsberg, thank you for making that difference. You attribute that in part to the length of a relationship, but we have seen that after menopause, it seems like desire can take a nosedive.
Mm-hmm. Yes.
And so you can be in a long-term relationship before menopause, still have active desire. The relationship may not be that much longer, and then you notice a significant difference. Can you explain what factors create that?
Absolutely. And thanks for asking that. So, and again, it's not necessarily the age of the relationship at that point. So at midlife with menopause, there are changes physiological that can affect both your vaginal function, but also your drive, right? That interest. So there are many factors. I remember I talked about neurobiology, and hormones for some women really can play a role. Now, testosterone, believe it or not, is an important hormone for women as it is for men, but women don't really recognize the fact that testosterone is important for their drive as well. And some women, not all, will notice a decline in drive that is related to a decline in their testosterone levels. Now, we have about 1/10 of the amount of testosterone that men do, right? And 50% of our testosterone is produced in our ovaries. And with menopause, our ovaries are essentially shutting down. And so what we had in terms of testosterone levels in our mid-20s has started to gradually decline over the years. But by the time we are 50, our testosterone levels are about half of what they were in our 20s. And some women will notice that decline and feel the experience of loss of drive.
And can women have comparable losses of testosterone or another hormone, but react to those drops in different ways?
Exactly. So some women will notice that decline, some women will not, and they will maintain good drive, but it is a noticeable change for many women. So it's an interesting thing about, well, what are we going to do about treating desire problems in midlife women? We have many treatment options. So back to my biopsychosocial model, for some women, when it is belief systems or negative values or relationship issues, then psychotherapy, which I do for a living, can be very helpful. Mindfulness-based approaches can be very helpful to keep people in the present. Some basic sex therapy when there are problems with the couple. You should always think about the partner there. And then there are pharmacologic options for women who really have a change in their drive. Okay, that's the women who will say, everything else is good. My belief system is good. My relationship is good. My values about sex are fine. But I've lost my appetite. That becomes the woman that might benefit from a pharmacologic option. Now, for a postmenopausal woman, there are essentially 3 treatment options. Testosterone would be one option, and by testosterone, I mean topical, or what we call exogenous topical testosterone, not pellets, not injections, not oral, but a topical gel. Right. We have actually the International Society for the Study of Women's Sexual Health has a clinical practice guideline for those practitioners so that they know how to properly prescribe off-label testosterone for women. Unfortunately, there are no FDA-approved testosterone products for women. What we know, and there is an international consensus, a global consensus publication on this, we do know that exogenous or topical testosterone has been shown to be effective for postmenopausal women who have hypoactive sexual desire disorder. The evidence is clear. What we don't have is an approved product. Only Australia has the only approved testosterone product for women. So unfortunately, that leaves practitioners here in the US and Europe having to use what we call off-label. That means it's a treatment that doesn't have an indication, but can be used. And so at this point, we strongly recommend to use a male-approved product one of the gels, and you titrate that dose down to what would be a premenopausal level. You want to get the women's testosterone back to what they were in their premenopausal years. So essentially, if you take, for example, a topical testosterone gel, it comes in a little tube. One of those tubes would be used daily for men, and women would use about 1/10 of that tube per day, right? And that would be essentially the equivalent amount, because you know, some women will say if a little is good, a lot is better. No, we're just trying to get your testosterone levels back to what they were in your premenopausal years.
So is that, someone asked the question, is that in your 40s or in your 20s? What
can we split the difference and say in our 30s? So there is a range. So there actually is a premenopausal level that is a range from, you know, not to be too technical, but let's just say 20 nanograms per deciliter to 70, and you want somewhere in that range, right? And that would be what has been studied over the decades of what a normal level for a premenopausal woman would be. Okay, so it doesn't necessarily have to be when you're 25, because there's a range. And some women will notice that drop and some women won't. What we don't want is to move you to a high what we call super physiologic range. We're not trying to get you into a male dosing. We just want you at sort of the middle ground of what you were in your premenopausal years, okay? And so a topical option is good. Please stay away from pellets because they will give you super physiologic doses. Be very careful about what you get. Compounding pharmacies sometimes are used, and you know, we would prefer you not to use compounded testosterone products. You don't really know what you're getting, but if that's the only option, then that would be an option. But the male versions are really what we would recommend. So that's option number one.
Someone just asked, what's the name of the testosterone gel?
Well, there's actually, it is generic now. So you can get generic versions of Testum. And the reason I like the generic of Testum is because it comes in a resealable tube. So if you can get whatever version in a resealable tube, it's nice because you're only going to use 1/10 of it every day. And some of the versions, like with Androgel, come in these sort of packets like you would get your soy sauce at a, you know, takeout. They're just hard to reseal. Yeah. And so it's all about the practicality of it. Get the kind with the tube. Some of them come in a pump, and that you can have the pharmacy then titrate the pump so you get the same amount. But so it's either a pump or a gel. It's all a gel. But it's how you can sort of get it out, because you're only going to use 1/10. That makes it the option of choice.
And you said there are two other.
So wait. So the other thing is that they are not, since they are not approved, you have to pay out of pocket. So your insurance will typically not cover. Every once in a while, somebody will, but it's typically not covered. So you're going to have to go to GoodRx or one of those other places. You can find it relatively inexpensively, but that's also what you're going to be thinking about in terms of cost. So that is option number one. Some women will respond. It's probably about 50 to 60% of women who have decreased drive at menopause, right? And if they notice that it's been declining in their perimenopausal years, that's probably a good sign that maybe testosterone might be the first option for you. But there are also two other non-hormonal options that are FDA approved in premenopausal women. So the way the FDA has required drug companies to develop drugs for women with low desire, it's you either test them in pre or post-menopausal women. You can't combine them, even though these are non-hormonal options. And so they have been studied, although the first one has been studied and published, and I've been an author on them, in postmenopausal women. It has not yet been approved in postmenopausal women. The first one is called ADDY, A-D-D-Y-I, and that's generic name is flibanserin. And that was originally, you know, more or so ago, being looked at as an SSRI, an antidepressant, a selective serotonin reuptake inhibitor. But it turns out it isn't an SSRI. It is a mixed serotonin agonist, antagonist, meaning it has a little bit different effect. It does not help with depression, but it actually has an improvement in sexual desire. And so that is, it's a nightly pill. You take it every day or take it at bedtime. It's a 100 milligram pill, and that is non-hormonal. So it works in the brain. It's like a CNS drug, right? And it works probably about 60% of the time. It has a 60% efficacy rate. It is approved to women up to 60 in Canada. So if you're lucky enough to be a Canadian postmenopausal woman, if you're out there, you can get that. And it is, anyway, so that's the first non-hormonal option. It's called Addyi. The other option is called Vyleesi, Vyleesi. And Vyleesi is interesting in that that is a subcutaneous injection, like an EpiPen, and it works on demand. So you use it essentially as needed, equivalent, if you will, to how men would use Viagra. Women would use Vyleesi for desire, not for arousal, but for desire. But it works in about 45 minutes. It starts to work, and it lasts about 16 hours. Okay, so it's in and out of your system, and so you have options. Addyi will work. You just take it every night, and it's sort of on board. And Vyleesi would be for women who are like, I don't really want to take a drug every single day. I'd like something that works when I want it. And so you have a couple of options.
We have a number of questions especially on testosterone. We're going to move on now, but we're going to come back to that at the end. And as I said, if we don't have time for all the questions, we will bring you back, Dr. King.
I promise I'll come back.
Because these are obviously complicated issues and people have very important questions on them. I wanted to turn to arousal. And I wanted you to explain how arousal differs from desire. And, you talk a little more about, how we understood arousal in a linear way. And, that's how Masters and Johnson presented it to us, but that's not the understanding anymore. So give us a little more information on arousal. Is there anything women can do to improve their arousal?
So arousal, we now differentiate into cognitive arousal and genital arousal. So cognitive arousal is different than desire, essentially by timing. So desire is the anticipation of a sexual event or a sexual encounter. It's wanting, right? Cognitive arousal is while you are sexually active, while you are in the act of some sexual activity, you are experiencing pleasure and enjoyment, right? Your mind is in it, not just your body responding, okay? And then genital arousal really is the ability of your body to feel sexual pleasure with sexual stimulation. So for women to notice lubrication, genital swelling, the blood flow to the genitals, to the vulva, to the clitoris, in the vaginal swelling, if you will. So, and the ability to feel that sensation. I'll see women who have problems with arousal who will say, my partner could be touching my clitoris and they may as well be touching my elbow. They can feel the sensation, but there's no pleasure to it. So arousal is the ability to feel sexual pleasure, right? It's not orgasm, but when we are differentiating arousal problems from orgasm, right? If a woman says, I can't reach orgasm, but I can have arousal, now we're looking at an orgasm problem, right? But if she's never able to feel that sexual sensation and also then can't have an orgasm, it's really an arousal problem, right? You need the arousal in order to have an orgasm. So for women out there who are saying, well, do I have an arousal problem or I have an orgasm problem? If you don't have arousal and also don't have orgasm, you probably want to focus on getting the arousal treated. But if you have good enough arousal, but you just can't trigger that orgasm, now you've got an orgasmic problem. So what can you do about arousal problems? If you are a postmenopausal woman, one thing to think about is, are you well estrogenized in the vagina? Do you have the ability to feel that sensation, right? And so now we'll probably move into the topic of genital urinary syndrome of menopause. But with the loss of, again, ovarian hormones, not only do you experience hot flashes and night sweats, but estrogen and hormones and androgens are really important for the urogenital tract. That means for blood flow to the tissues. Oh, there we go. We have a nice little image there. So with menopause, without estrogen and androgens, things change. And this happens gradually over time. So while you might notice hot flashes and night sweats, and they will eventually go away usually, genitourinary syndrome of menopause does not. It is chronic and progressive, and it can affect up to 70% of women. So without that, the hormones, the tissue in the vagina, in the vulva, becomes thin and dry. You can see in sort of that close-up, without estrogen, the layers of tissue kind of wear away. They become thin and dry and easily torn, which is why women will say, well, no wonder it hurts when I try to have penetrative sex. The vagina itself can actually narrow and shorten. And you can see on the left, those nice folds like a pleated skirt. Dr. Jim Simon always talks about the rugae in the vaginal walls of a healthy premenopausal woman as really sort of like a pleated skirt. And without the estrogen, it becomes very thin and dry, right? And they lose those nice healthy folds. So what you can do is replace with hormone therapy, vaginal hormone therapy, whether it's vaginal estrogen or vaginal DHEA, dihydroepiandrosterone, or an oral, what we call term called aspemifene, though there are treatments to restore that tissue. And that will probably help with arousal. For some women, we also are looking at a vaginal sildenafil, or Viagra, if you will. We're in clinical trials looking to see if a topical cream that is a sildenafil might also help with arousal in some women, and that would be pre and hopefully post as well. Okay, did I get the arousal answer?
So how do you, because before we go to orgasm, I want to go back to the genitourinary syndrome of menopause,
okay,
and what it does both to arousal and to pain. Because you showed a picture, obviously, what happens to the vagina, and many women talk about increasing pain after menopause.
Yes, and they should not be suffering in silence. And if your practitioner, menopause, GSM, used to be called vulvovaginal atrophy. But 2014, we had a consensus conference. I was part of that, and we changed the name. Why? Number one, who wants to be told that your vagina is atrophying, vulvovaginal atrophy? That was really kind of harsh for women to hear. Number two, VVA, vulvovaginal atrophy, was not actually representing all of the changes that happen when you lose hormones, right? Because it also affects the bladder, right? The urethra. So some women are going to notice they're going to have pain with urination or more frequent UTIs. And some of that is due to the change in the vaginal microbiome, right? And so it can affect the whole urogenital tract. So that's why it's genitourinary. And third, talking about vaginas is not always been easy in the media. I can say vagina, vagina, vagina now, thank you. But for many years, to have a news interview or to be on television sort of talking about these problems, okay, Dr. Kingsburg, you can talk about anything you want, but don't say the word vagina. So that was really a problem.
So I'm going to ask you now we are going to provide a transcript of this just so everybody knows, so people understand exactly what you're saying and what's it called. But I want you to go a little more slowly now. And I want you to tell, again, you talked about them deeply related to arousal. Please go through slowly what the options are for women to treat a very dry, painful vagina.
So, sorry.
And clarify whether they're hormonal or non-hormonal.
Sure. So genitourinary syndrome of menopause, GSM, which happens in at least 50 to 70% of women, are the signs and symptoms, right, that include dryness of the vagina, whether or not you're sexually active, right, and the thinning of the tissue. So you might feel pain, whether or not you're sexually active. And when you think about treatments, you can use a non-hormonal treatment. So if you are going to be sexual, I would strongly recommend you use a lubricant, whether or not you're doing anything else. You use a lubricant, and many premenopausal women are using lubricants. It is a multi-million-dollar industry. So you can use water-based or silicone-based. You know, if you are prone to pain or infections or bacterial vaginitis, you might think about getting paraben-free ones. There is a term called osmolality that has to do with the amount of moisture that lubricants can provide. And so postmenopausal women in particular need to pay attention to the kind of lubricant they have so it doesn't actually cause more dryness. But lubricants during sexual activity, very, very helpful. You can also use a moisturizer. So you use a lubricant during sex, and a moisturizer would be just like you use moisturizer on your skin. You use it, you know, a couple of times a week, and it can help restore some of the moisture to tissue, but it will not restore the tissue. Okay, so lubricants during sex, moisturizers just like you would moisturize your skin in the middle of winter. And then you can move to a hormonal option, right? Vaginal hormones, which are very safe. They have virtually no systemic absorption, meaning it doesn't get to the rest of the body through the bloodstream. Very little absorption. And those are used in the vagina to restore the tissue back to the, you know, the healthy layers of tissue. It helps restore the moisture and the thickness of the tissue. And so vaginal hormones come as vaginal estrogen, which can come as a little pill that you insert in your vagina, a little gel cap insert that kind of looks tear-shaped. There's a ring that you can put in and it will last 3 months. And there's a cream that comes in a little applicator, or you don't even need the applicator, just use your finger and you can insert it. Those are the vaginal estrogens. Then there is a vaginal DHEA called prasterone. So that is, the brand name is Intrarosa, and that is a non-estrogen. So it doesn't carry the same warning label, the boxed warning that vaginal estrogens do, which we have been trying to have removed for years because it doesn't carry the same risk at all of systemic hormones, but vaginal prasterone, right, comes as a little vaginal insert as well. And then there's an oral option. So for women who really don't like to insert something into their vagina, there's actually an oral option called aspemifene, which is a SERM, a selective estrogen reuptake modulator. And so it doesn't have any estrogen in it, nor does DHEA. And so you have a variety of options that have been shown to be effective to restore the tissue, again, back to that premenopausal healthy estrogenized tissue. And while hormones you might not need for the rest of your life systemically, if you have vasomotor symptoms, you will probably need to stay on your vaginal treatment for the rest of your life. Just will.
And so how does Aspina fit into that? Is that because we had several questions. Someone said they were on Aspina that was actually helping their vagina, but many of their doctors wanted them to go off it. And what is the method by that, the effective action of that? It
works very similarly, except it's an oral option, but it does work to restore the tissue, but it does not contain estrogen. You know, SERMs have been our sort of synthetic, non-hormones that work in some areas and act like an estrogen, and in other parts of the body, they don't. And so one of the things about SERMs is that they can work to help, say, in this case, with vaginal health, but it will not impact the breast, right? So many women who are really, sort of staying away from anything that has the word estrogen in it at all would think about Aspina, right? But it happens to be an oral option. It works the same way, but it is an oral option, and it is a non-estrogen.
And one person asked a question, does DHEA convert to estrogen? Is that true?
It does. It's an interesting, biochemistry issue, but it is a non-hormone, right? It's a pro-hormone, if you will, DHEA, but in the cells of the tissue, it works like an estrogen and androgen. So it converts to both estrogen and androgen, but it is not, so it's metabolized in the cells, but it does not work in the bloodstream the same way. And so it is different. It doesn't carry the same boxed warning because it is not an estrogen, but it works to convert to estrogen and androgen metabolites in the cells.
Okay, we also got a number of questions. If you take a local estrogen, vaginal estrogen, and it just doesn't do enough, that sex is still painful. Some people are asking, can you mix and match these different things? And how do you think about that?
I would say that's the thing you have to go back to your practitioner and say, this one is not working, right? This is not working. And it may be that there's something else going on. So please pay attention to whether or not it's actually genitourinary syndrome of menopause. There are many other vulvar conditions that could be causing pain, and you want to make sure you have ruled them out. And can I please put a plug in for pelvic floor physical therapy?
Yes.
We can talk about that, but for many women who, because of tensing, because they've had pain, or just as a matter of how they carry themselves, or there's pelvic floor dysfunction, and one of the best professions in the world to help with that are pelvic floor physical therapists, and they can help. Even when sometimes there is pelvic floor dysfunction, it can be experienced as what seems like vulvar or vaginal pain. So that's also something to be assessed and checked on. So when you say, can you mix and match? I would say, please don't just sort of throw the kitchen sink at something. Look at what the underlying condition is, because if it's a dermatologic condition, say, there's all kinds of vulvar conditions that really need to be treated differently. So like in sclerosis.
We have a lot of questions still on vaginal estrogen, on pain during sex. We're going to double back. We don't have a lot of time. We will double back to these questions. I want you to talk about the fourth component. And then, as I said, we're going to go back. We have a number of questions on vaginal estrogen and testosterone. Talk about orgasms and why you said you don't have arousal, it's going to be hard to have an orgasm. But there are many women, and you talked about this, who can get aroused and cannot have an orgasm, and especially post-menopause. Again, why is that? And what are the options for that?
Well, it is obviously very distressing to women to really build up the ability to have arousal, and then they just can't trigger that orgasm anymore. So let's separate out lifelong anorgasmia. And there are, unfortunately, anywhere from 5 to 10% of women who have never been able to reach orgasm. For some, it's lack of support or education. They don't know how their bodies work. For some, there seems to be some kind of neurologic issue, and so not everybody will be able to achieve orgasm. We're actually working on a ISSWSH consensus paper on orgasm, just like we did with testosterone. We're going to work on one with orgasm. But for those women who were able to reach orgasm and now cannot, right? When we say cannot, some women just can't reach orgasm at all. For others, it now just takes a long time, or it's much more muted, right? They used to have these big, strong, scream from the rooftop kind of orgasms, and now it's very muted. So all of that would be considered problematic with orgasms. And so for some women, giving them back estrogen so that the tissue is healthy and they can feel the genital sensation, that might be very helpful. For others, for example, the topical Viagra or sildenafil might be helpful to increase blood flow. And a lot of it is blood flow. But for some women, particularly again, as we age, vibration becomes, there are different nerve endings that do change as we age. And so for many women, they're like, well, why, I used to be able to reach orgasm with oral sex, or I used to be able to reach orgasm with penetrative intercourse, and now I can't. It is a fact that you may have to now start to incorporate a vibrator. Because the vibration reaches different nerve endings and different tissue, and than you used to be able to sort of rely on in your younger years. So that becomes the key of finding a vibrator that works for you. And fortunately, that is also a multi-million-dollar industry, and there are millions out there. Well, maybe not millions, but there are hundreds of different kinds of vibrators. You gotta, that one would be a mix and match and see what works for you. And having that conversation with your partner about incorporating a vibrator when you may not have had to in the past, to bring that in so that he or she does not feel like it's something wrong with them, but that this is now just a natural part of aging that we need to incorporate, because having an orgasm is a really satisfying part of a sexual encounter. And you don't want it always in your head of, well, why bother because I can't, or will I, right? You want to be able to have more confidence in that sexual experience.
Someone is asking, I think, a very important question about if you take systemic estrogen, to what extent does it address all four of these challenges?
Well, probably the systemic estrogen can often prevent GSM, but not always. So I do get that question a lot when they'll say, well, I'm on systemic hormone therapy. What's going on here that I'm still having dryness or pain with sexual activity? And for those women, systemic hormones is not enough. They're going to need a vaginal hormone therapy to address GSM. So do not assume that if you're on systemic hormones, it will cover it. Many times it will. Now, it will not address desire. Desire really is not about estrogen, right? It's not about estrogen or progesterone. That's going to be, again, neurochemical. It's either going to be your neurotransmitters or it may be testosterone related. But as systemic hormone therapy, estrogen, progesterone will not, or progestogen will not address that. Arousal, it may help, right? Same thing. If you have systemic hormones and it is working to prevent GSM, it probably will also be helping with arousal, which will then lead to the ability to reach orgasm, but not guaranteed. And back to the pain, obviously, it's all about GSM and trying to make sure that if you're on systemic hormones, it does enough. And if not, you tell your practitioner, it's not enough and I need something else. Don't take no for an answer. Do not suffer in silence.
Okay, Dr. Kingsbury, but the reality is, and it happened to me with my own NAM certified gynecologist, when I approached her and said, I can't even have sex anymore because of GSM. And she told me to buy an over-the-counter lubricant and use it or lose it. And so even though it was actually impossible, and you have that aspect of the situation, but you also have every woman having to figure out for herself after she goes through menopause, like every woman's whispering, what is happening to me? With
Sure.
No one really understanding this. And actually a primary care doctor asked the question, like, should we be proactively giving women?
Yes.
Well, she's asking, should we be giving them topical estrogen, or do you wait? And how long do you wait?
So first of all, by proactive, this conversation should be started in your 30s and 40s with your practitioner so that they know to anticipate and you know to anticipate. Should the proactive, by the way, the use it or lose it is an interesting concept because sometimes the vagina will narrow, and you bring up another issue, which is what we call vaginismus, which we didn't talk about, which is the involuntary tightening of vaginal muscles because of anticipation of pain. So if you, for example, started to have pain and you couldn't even have penetrative sex, and then let's say we gave you back some vaginal estrogen, but your vagina is saying, well, Jessica's nice and all, but she's not too bright. She keeps trying to put something in that's going to hurt us. The muscles automatically tighten up. And so we can use dilation and gradual, that's where cognitive behavior therapy comes in with gradual exposure to retrain the vagina that you as the owner can be trusted to allow for pain-free penetration. Now, we do know that exercise and stretching the vagina doesn't have to be sex. It can be your finger, it can be a dilator. It's very helpful to keep the vaginal opening, stretched and not so tight and anticipating a pain. So that part is the use it or lose it. We do know that that is actually helpful, but it's not really the right thing to say, well, use it or lose it because now it's your fault. It is, we want to keep the vagina and the tissue stretched.
So a number of people have asked, you mentioned lubricants and daily moisturizer. A lot of women do not have success with those. Is there a moisturizer that you found does have a better track record of success?
Well, it's success at what? So, and it's not a daily moisturizer. You use the moisturizer a couple times a week, if you will. And honestly, if it's not giving you success, then you should be thinking about a vaginal hormone therapy, right? If you're still dry, then you need to move on. And the moisturizer, I think the hyaluronic acid moisturizers tend to work a little better, and so they're nice, but really that's going to be a mix and a match and find what works. They're over the counter, so you're going to have to, you have to pay out of pocket for them. So you want something that works. But if you're finding that you're really dry and it's uncomfortable, then moisturizer is just not going to be enough.
What about our people are asking if they're breast cancer survivors? I know this is a very complicated issue, but I'd like for you to talk about how you handle that issue, even in terms of local vaginal estrogen.
So there are many practitioners now, and the American College of OB/GYN has come out with publications and practice guidelines that say it is not an absolute no. If you are a breast cancer survivor, and think about quality of life issues, think about, Jessica, your description of you couldn't have sex. Many oncologists now are aware of the fact that the amount of systemic absorption, which is almost none, makes a vaginal hormone therapy safe, right? You're not getting systemic absorption. There is the Imvexxy, which is a gel cap, has a 4 microgram and a 10 microgram dose. So for a lot of breast cancer survivors who are really anxious about it, there's a teeny tiny dose in there. The vaginal DHEA has no estrogen in it, doesn't carry the boxed warning. And some would say, well, but it still could convert to estrogen. Look, talk to your practitioner and talk to your oncologist and have that conversation. There are many oncologists who now understand the importance of having good vaginal health and treating GSM, and are recognizing that even as a breast cancer survivor, you can safely take these vaginal hormones. And though the trickiest population is going to be the women on aromatase inhibitors, which often actually have some of the worst GSM.
Can you explain what that is just for our audience?
So an aromatase inhibitor is a particular, once you've had breast cancer are now on sort of treatment long-term to prevent recurrence, an aromatase inhibitor acts as an anti-estrogen. And so many will say, if you're on an anti-estrogen, you don't want any amount of estrogen in your system. And so that becomes a conversation between you and your oncologist, hopefully your primary or OB/GYN in there too, having a conversation about whether that teeny amount of vaginal estrogen would be okay. And sometimes it's a quality of life issue, and that really is a conversation to be had. Don't just assume no, have the conversation. It might be no, but have that conversation.
So we're going to have to close for now because we have a survey to give you all. We want to talk about our menopause talk. I guess one final thing, Dr. Kingsbury, you've talked about these 4 categories, and interestingly, you've mentioned some overlapping treatments for these different categories and some separate treatments. So to actually get it all working, if you're having issues, can be a lot of steps. And there's an issue of finding the doctor who's knowledgeable. And I want you to remind people now, you are licensed to practice in how many states now?
psychologist, so I do cognitive behavior therapy. Clinical psychologists now have the ability to have sort of reciprocity across states, and so about 35 states. But you need a NAM certified practitioner to be able to give you the best advice about menopause and hopefully GSM. And if you're not if they're not talking to you about your sexuality, find another practitioner. Really, 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 really.
And it's not only hard to find a doctor, this can be a challenge for women to discuss with their partners because there are things you have to do differently. Like you mentioned a vibrator. If you haven't used a vibrator before, there may need to be a different thing at the beginning. You may need to take a pill before you start. So do you also talk with your patients about strategies for communicating with their partners about these issues?
Absolutely. And by the way, I often ask about partner function too, because sometimes a woman will come in and she'll say, there's something wrong with me, but it turns out that maybe the partner is having some sexual dysfunction, and that's really where you need to be addressing it. But yet I actually have published several papers on partners' attitudes and experiences of their female partner with GSM or menopausal symptoms. And we're continuing to do that kind of research. And it is so important to have that communication. It's surprising that partners really want to know, but it becomes, sort of hot potato. If you're having pain, your partner's going to experience that and may also then lose their interest in, because they don't want to hurt you. Right. So that you need that conversation so that you can find ways around it. And in fact, when there are limitations to what you used to rely on as your same old sexual activity, sometimes that's helpful, because now you actually have to talk about your sexual activity and your interests and patterns, and changing it up a little, even when it's because of a problem, can actually be helpful to a couple's sexual life.
So I want to thank you on behalf of Let's Talk Menopause and our audience. I promised you all you would not be disappointed with Dr. Kingsburg. We already got her to agree to come back for a question and answer session, hopefully in April, to continue to delve deeper into these topics. And you'll also have an opportunity to learn more if you join us at our March 10th live half-day symposium in New York City. And we will be talking about sex and mood and more during perimenopause, the menopause transition, and beyond. And we've actually, Dr. Kingsburg is going to be both on our sex and GSM panel and our mood panel. You can go to letstalkmenopause.org to register and to learn more about our upcoming menopause talks. And again, we just wanted to thank you, Dr. Kingsburg. We will make a recording and we will make the transcript available. Please reach out to us if you have any questions. I know a lot of things she said, Dr. Kingsburg said, were fast, and it's hard to get down the names of all the different treatments and medicines. So thank you for participating. We are going to provide a survey now, and we hope you fill it out, and we will also send you a thank you with a link to a survey, and then you'll get the recording probably next week. Again, thank you so much.